Hi guys, welcome back to Codemaster Coach, your medical coding tutor. We are continuing our studies on risk adjustment. Guys, my risk adjustment information is coming from Risk Adjustment Documentation and Coding by Sharon Poe Bernard, and this book can be found at the American Medical Association. All right, continuing. Risk adjustment, we said in my previous video, is basically a tool that determines how much money is needed to care for a patient based on how healthy or unhealthy the patient is. And we said in risk adjustment, the severity of illness, as represented by the International Classification of Diseases, 10th Revision Clinical Modification, which is our ICD-10 classification codes, determines payment for insurance companies. So let's look at coding and payment generalities. Diagnoses are the cornerstone of medicine. However, the accuracy of ICD coding has not been a focus for coding except when the codes affect hospital payment. For physicians, current procedural terminology, our CPT codes, have traditionally been the focus of regulatory scrutiny, as these have been the money codes. As long as ICD codes captured medical necessity, they weren't scrutinized. Risk adjustment and quality incentives have changed this. Today, payments are also tied to the resources that a patient may be expected to require based on the diagnoses associated with the patient. These diagnoses include the reason for the current encounter and any underlying diseases the patient may have. Notice Sharon Poe Bernard stresses this. So, the two-pronged goal of diagnoses-based risk adjustment is 1, to ensure conditions are diagnosed, documented, coded, and regularly monitored, and 2, accurately track the care requirements of patients so that future demands on resources can be predicted. Because think about it, if we don't encompass everything that's involved in that patient care for that visit, if we don't capture all of those additional comorbidities, we're not really showing a true representation of what resources were used for that visit. And there's a note, previously risky patients with pre-existing conditions would not be able to find insurers willing to cover them or face unaffordable premiums and deductibles. The Affordable Care Act aimed to make insurance available to more Americans because, remember, insurance companies couldn't afford to handle them. So with risk adjustment now, we're taking that factor in. What does this mean for physicians and coders? For the record, it must be specific, it must be accurate, it must be clinically valid and unambiguous. And the coding must be according to the guidelines, accurate to the highest specificity, and it must be complete. So example, physician's office may sometimes document or code for less detail or accuracy than is optimal. Because think about it, with code Z00.00, which is encountered for a general adult medical examination without abnormal findings. This code captures the medical necessity, but it does not capture the comorbidities that may risk adjust, such as your pre-existing hypertension or diabetes. We're quick to identify that Z00.00 code for the encounter, but we don't capture those pre-existings. Also, code K70.30, alcoholic cirrhosis of the liver without ascites. Guidance at that code instructs the coders to use an additional code to report alcohol abuse or dependence, and by not doing so, omits a valuable risk adjustment payment. I've used the K70.30, but there is a note at that code, guys, that says to use an additional code to report the alcohol abuse or dependence. So, what is a value modifier or VM? A calculation that considers the quality and cost of care provided to Medicare enrollees under the Medicare Physician Fee Schedule and compensates healthcare physicians for high-quality care and for care of patients with high risk due to comorbidities. It is also known as the physician value-based modifier. Now, the value modifier program assesses the quality and cost of care provided to Medicare beneficiaries by solo practitioners and medical groups. CMS uses risk adjustment in the evaluation of differences in Medicare spending per beneficiary to allow for more accurate evaluation of physicians based on the quality of their services and patient outcomes. Without risk adjustment, physicians who treat a sicker population of patients could perform worse on some quality and cost measures because it's going to look worse than like they're treating sicker patients. When in actuality, we need to give them credit for treating sicker patients. So the value monitor measures that risk adjustment includes are 1, a 30-day all-cause hospital readmission. This will risk adjust for age and underlying risk associated with surgery, gynecology, general medicine, cardiorespiratory, cardiovascular, and neurology. And for this given population, some readmissions are considered unavoidable, and then the planned readmissions are excluded from inclusion in this measure. Hospital admissions for acute and chronic ambulatory care, sensitive condition composite measures. In this one, age and sex both affect the likelihood of hospitalization for patients with acute and chronic conditions. Evaluations of these hospitalizations can identify physicians who are engaged in better primary care, care planning, and care coordination. Acute conditions measured are dehydration, bacterial pneumonia, and urinary tract infections. Chronic conditions include diabetes, chronic obstructive pulmonary disease or asthma, and heart failure. Another, per capita cost for members with specific diagnoses. This measure compares projected cost for care against the actual costs. And consumer assessments of healthy care physicians and systems for PQRS. In this situation, case mix is a consideration in the scoring of the consumer survey enrollees complete for their physicians. So again, look back over my previous video and then this as we go into looking at models of risk adjustment in my next video. Okay, guys, thanks, and I will see you in the next one.